Our topic for today is algorithmic discrimination and health equity and solutions for a fairer future. So we have really a great group of panelists up here today to help us navigate this complex question. And it'd be great if it's we build and think about some of the things that were said earlier. So artificial intelligence obviously promises substantial advancements in healthcare, but it also raises anxieties about bias and its effect on health equality. So whilst it could be a great equalizer or leveler, as we said before, it could also exacerbate health equity challenges. And as beneficial as it is, it could also cause social inequities and even jeopardize patient well-being. And there have been historical examples of that. So this panel will delve into these topics, and really what we'd want to get as an outcome of all of this is recognizing the effects of algorithmic bias on access to care, quality and care and health outcomes, and then exploring concrete solutions to foster a more equitable healthcare system. So I have the intros here for each and every one of you. I just received them, so I'll ask you guys to introduce yourself first before we kick off with the questioning, if that's okay. Dr. Saira, I'll start with you, please, first.
Thank you very much. So I'm Saira Ghafur. I'm the lead for digital health at the Institute of Global Health Innovation at Imperial College London.
Could you please hold the microphone a little closer?
Is that any better?
Or maybe I should give you mine.
Is that better? Yeah. So I'm Saira Ghafur, the lead for digital health at the Institute of Global Health Innovation at Imperial College London. I'm a respiratory physician and also the co-founder of Prova Health, which looks at evidence generation in digital health, and another startup called Saira, which deals with online mental health.
Thank you. Dr. Katie?
I'm going to try mine. Oh, am I working? Okay. Hi, I'm Katie. I'm CEO of Awesome Health, which is a company looking to solve for neglected conditions in women's healthcare. I'm also a clinician by background, so practice in general medicine and in women's healthcare as well.
Stefan?
Thank you. Stefan Konya, Senior Advisor and Innovation Portfolio Lead at the Office of the National Coordinator for Health IT in the U.S. Department of Health and Human Services. So I work for the U.S. federal government. My job is to connect with the startup and investor community and the innovation community in the U.S. And globally, and then also to evaluate emerging technologies and trends in the U.S. and to see what we should be doing from a regulatory standpoint on those types of things.
All right, thank you. And I'll just point out as well that we'll leave a couple of minutes in the end as well for questions. We want to keep this interactive as well. So, please, if you have any questions, please think of those up front. So I'll start with you, Dr. Katie, first. How can technology be used to reduce health disparities among different population groups? We've touched a little bit on that now, but would love your opinion on that.
Yeah, I mean, that's a huge question, which I don't think we can cover all of today. And as you mentioned before, obviously health technology can be used to improve health disparities. It can also be used to worsen them as well, as you mentioned, in terms of if we don't look at access, if we don't identify demographics, if we don't look at language and the ability to use it properly. I guess I'm focusing, if we focus today on what it can be used to help, so how can health technology be used to improve health disparities? There's kind of three ways I think that it can be useful. One is kind of identification of those conditions in these neglected populations that are currently not being identified in healthcare, and I'll talk a bit more about that. The second piece is how technology can be used to collaborate across groups such as clinical groups and social groups to help with, as you mentioned, the social determinants of health. So using technology to bring together different parts of healthcare to improve outcomes. And the third thing is in access. So I think technology, as you mentioned, the mobile phone, allowing populations, for example, in rural America, there's huge amounts of the population there. Women there, some women have to travel 200 miles to get a physical examination. So how can we use technology there to improve health outcomes? So I guess they're the three main areas. Because the panel's about algorithmic discrimination and health equity, I thought I'd touch on the first one, which is how do we identify those neglected, those conditions? And that's kind of what we're doing at Awesome Health. So in women's healthcare, as I'm sure many of you may know, there are conditions which take up to 7 to 10 years to diagnose due to inequity in health from not being included in research, for example. So we're looking at building, using data and population health level data, algorithms to try and identify these conditions for earlier diagnosis and better intervention for these populations. As you mentioned, algorithmic discrimination has to be thought about here, because we could actually worsen health disparity, particularly for women from minority backgrounds, if we don't label the data correctly and if we don't think about kind of the limitations of the models and identifying those to make sure we're continually trying to improve them, as well as having a clinician in the loop to ensure we're not, again, causing harm by this. So, yeah, it's a huge question, but I think 3 ways technology can help is an identification of these conditions, improved access to care, and cross-collaboration amongst groups to solve for social determinants alongside clinical care.
Thank you, Kane. So, one of the things that I often find most challenging in this is technology broadly is there, but the data and the quality of the data is not. And we talk a lot about social determinants of health, but the reality is that a lot of places have quite weak social determinants of health data as well. So I know I'm springing one on you as well, added to this, but I just wonder if you could comment on that, given your sort of experience and in the segment as well on, that sort of quality aspect. How do we make that a more contextualized experience for both the caregiver, let's call it, and the consumer, but also what are the ethical considerations of use, of the use of technology to be able to collect and analyze health data? Dr. Saira.
Still not working. So, when you're looking at the ethical considerations, I think one of the key points is you're asking people for their data and how we use that data at the end of the day as well. So in terms of data privacy and security, you have to be at the forefront of one's mind, making sure that we say what we'll do with the data, and these are the intended outputs of what we're going to use for whichever algorithm is created based on the data. The other point is security of any data. So we've seen over the past couple of years the number of cyber attacks against healthcare have risen 5-fold. This will only ever increase, and especially when you've got data across the whole kind of landscape from consumer to healthcare system. You've got to make sure and reassure patients and the public that this is very secure. But again, back to the algorithmic discrimination point, and what we would look at in terms of ethics there, it's back to that inequities piece. And it's what data are we collecting, how are we collecting it, and what are we going to use it for. And it's very, very clear that you can propagate any inequities if it's not collected well. So any data-driven solution is only ever going to be as good as the data that it's based on. And this was very, very evident through the COVID pandemic when we saw the inequities in healthcare. And this should never have been a surprise to anybody, but over years and decades, it's poor quality data that resulted in some of the kind of inequities that were displayed that were a surprise to people. So data is only ever going to be or outputs are ever only going to be as good as the data that they're based on. So we've got to make sure that we're collecting routine ethnicity-based data, sex, obviously racial data as well. So all of that to kind of make sure we're not furthering inequities in healthcare. And again, as I said, any data-driven solutions will only be as good as the data they're collected on.
Great points, thank you. Handing it over to you, Stefan, then as well. We talk a lot about access, we covered a lot on data, but how do we ensure that technology is accessible and affordable for all, regardless of where they are, or also regardless of sort of their demographic group? Any thoughts on that?
All right, so I have a couple thoughts on this. The first thing is I just want to build a little bit off of what my colleague said here at the end around the data element. A lot of people, when they think of bias and all of this, when it comes to AI and the use of it, they're going to naturally just gravitate to data. And it's good because there's a lot of issues with the quality of the data. There's also a lot of issues with having enough access to truly representative data as well. And then there's also the question of the use of the data, right? So you may have the right data, but are you using it in the right way? And sometimes there can be both unintentional as well as intentional misuse of that data for somebody's own reasons. So something that we do in the US and something that we've done over the past several years is really look at this problem in a number of different ways. One is our White House, the head of our executive branch, established an AI Bill of Rights recently, in recent years. And it basically says that our citizens and those living in our country should have some level of right to understand what types of algorithms are being used in their daily lives. How are they impacting their access to housing or healthcare or other areas, their financial, getting loans, things like that. And being able to have awareness of how that is impacting their lives and what kind of data fed into it and so on. That's at a very general level with the states in there, but in the context of healthcare, we've looked at it in a number of specific ways. One is, for about 2 years, I was part of a jury panel with a number of other federal agencies, as well as a number of technology and healthcare policy experts, looking at specifically the misuse of race data and bias in healthcare algorithms. And actually, we have a manuscript coming out shortly that we co-authored on it. And it's going to give tips for how you can make sure that you're addressing some of these challenges as you're conceiving the model, building the model, testing the model, deploying the model, evaluating post-implementation the model, and ongoing monitoring of the model, right? So thinking through at every stage, how can you ensure that there's equal impact of the use of that algorithm to different populations and in different contexts and different settings. The other thing that we did on the federal government side is we didn't pass recently, we issued a public rule, which in the US is a way of us getting into the very fine details of a broader law. To say exactly what we can do to regulate additional areas of healthcare technology interoperability, but specifically what we called out was this area around predictive decision support interventions, or PDSIs. Sorry, I know government loves acronyms, but that is something that that we wanted to make clear, because in the past we had regulated clinical decision support technologies, right, CDSTs, but we hadn't really called out a broader ban of algorithms and a broader use of these types of technologies, which we think the predictive one gives us that leeway to go a little bit further. And what I mean by that is, number one, everybody's going to think of algorithms in the context of clinical care, right? Solutions that are going to, like some of your photos, evaluate somebody's skin and look at whether or not they could detect cancers and things like that. But a lot of people don't think about the potential for harm and or benefits with the use of algorithms in more administrative settings in healthcare. So scheduling tools or things like that, which isn't directly delivering the care, it's more the operation side of things in the back of the house. But we have studies that we've seen that have shown that certain populations are being impacted differently based on those algorithms. In fact, African American patients were being scheduled out significantly longer for appointments than white Caucasian patients. So it may take a white Caucasian patient 5 days to get an appointment for healthcare, or it may take an African American one 20 days or 25 days. And that's an issue of access to care and quality of care as well, right? So thinking through what can we do to try to make sure that these algorithms are affecting the entire population in the same way and it's fair. We proposed this new rule, and there was a principle. I think you said you had 7 principles or guidelines. We try to boil it down a little bit shorter in our regulations. It's an 800-page document, so we got to be short and sweet where we can. But in this case, we put forth a faves principle, and I would say it's my favorite of these, because I'm a dad and I like dad jokes. But faves is fair, appropriate, valid, effective, and safe. And that's essentially what we're trying to look at. How can we regulate and increase transparency and accountability of algorithms being deployed through electronic health records or built by them and delivered by them, to kind of take those 5 things into consideration. And then require some transparency around what types of data is being used. Because like I said, it's not just about having good quality data, but it's also about having wholly representative data, and then also understanding how you're using it, right? You could have good quality data that's fully representative, but if you're misusing it, then it can have bad outcomes, right? Or unequal outcomes. So in this case, we're trying to increase some transparency of that, so the users of these technologies, whether they be patients themselves, or whether it be the clinicians or the administrative staff at these healthcare systems, or community-based care settings, that when they're using them, they have some level of transparency into how they were built, what types of data are they trained on, how are they being used, what are the model assumptions that are baked into it, and is there a risk for biases or inequity? How has it been tested? And that doesn't get to the point of post-implementation monitoring that the organizations got to do themselves, but if we can at least give them a more informed choice on the front end when they use these solutions, we think it'll have better impacts for patients in the long run.
Great points. Thank you, Stefan. Does anybody have a follow-up? I'm just wondering on this topic that you'd like to add or contribute? We're good? Okay. I think your point around, the operation side of things is a great one. And we've seen how that could play out because, like you said, people with less access to care from an algorithmic point of view would say, well, then they don't need the care and then thus get out, don't get the schedules that they need or are not part of the health that's required to address them. So I think that's really, really important as we think about this. One topic that I think it'd be good to get your perspectives on as well is how do we think about, with generative AI specifically, where broadly the AI is to a certain extent creating or generating content, there's that risk of, as we've heard, like hallucination as a part of that. So how do we make sure that we're grounding that on factuality and that you're able to, just like any publication or statement that we read in science, it's referenced, and that you're able to see the ground truth of that. So I think thinking through that in terms of being able to have an AI response that's correctly labeled as an AI response, but being able then to go to that and understand what proves that to be true, the source, of that truth, also becomes a very important part of how we think about this. Let's shift a little bit to the role of community then. We talked a little bit about this. Again, very frequent type of conversation that I'm faced with is the scaling question. It's like, this worked really well here, but it doesn't work well there. It's the same technology, even broadly sometimes the same regulation, but it just doesn't lift. There's something wrong. Either it's something additional that needs to be embedded on the workflows. There's a cultural element that's there. I often think that, culture and people are often like 70% of the issue. Technology is broadly, the simplest side of things. Just wanted to hear your perspective on sort of what role could community engagement and collaboration play in shaping the development and implementation of technology-based solutions. In other words, we have a view from a Google perspective on how we scale, which was open sourcing a platform to allow developers to go and build. So let's not try and solve everything, but let others solve it, and we'll provide the conditions for them to be able to do it. But I would love to hear your opinions and what might be missing or things that we need to consider. And it's really a question, I'll start with you, Katie, but to all of you.
Yeah, I think, communities are going to be essential as we move forward in building technologies that actually impact outcomes, because it's all about the person in front of you that you're trying to solve a problem for. And if we don't include them in the development of these technologies, then I just think it's a non-starter. I can give an example of what we've been doing in terms of rolling out with a global client in our solution. And you mentioned culture, the way that we ask questions, the way that we talk about certain health topics from again, rural US to India, for example, are completely different. So getting community feedback and iterating on how we're talking about things to actually alter outcomes for those specific demographics, cultures, groups is extremely important. So I think I think we need to involve the people that we're providing these solutions for in the design, development and implementation, and continually get feedback to provide the solutions that we need.
Completely agree with all of that, and I think it's in my mind kind of try and separate out the two. You've got the evidence for your AI model itself, but you also need the evidence for the solution when you're implementing it into practice, and that goes beyond the kind of initial kind of system that you're trying to implement it in. It's the community base as well, so it's all of that feedback that you're getting, how you can then iterate it, improve it, and learn from any unintended consequences that will be very different from, say, in London versus Venezuela, for example. So it's going to be very, very different. I think the other thing is just touching back on that generative AI piece as well, those kind of contextual inequities as well. When you think about the inequities, a lot of the information or the data that's going in to these generative AI models are based on the global north. And then if they're being used in the global south, it's then again propagating that huge kind of set of inequities as well. So that's definitely where that kind of community and culture piece is really, really important down the line.
So since I'm the federal government guy here on this side, one thing is I'd say we talk a lot at the federal government in the US about health equity by design. So just as in society we have security by design when you're building technology stacks and you're thinking about a secure system from the start, we should be thinking about the equitable impact of these tools and these solutions, right? And like I said, through every phase of development, deployment, and post-implementation monitoring, we should be thinking about how does this have the potential to positively impact the equitable outcomes of the population it's serving, but also what could be the potential risks or harms, right? The promises and the perils, right? But in addition to that, when we think about that as a policy, government, I think, needs to practice what we preach. And we also need to make sure that we're designing policies in a way that are taking health equity into consideration. And so everything that we do in that policy-making process, we need to be just as inclusive as we're asking developers to be, right? Practice what we preach, walk the walk, not just talk the talk. We've got actually a couple other panelists, some of my colleagues from the US that are here, that you're going to hear about later today and tomorrow, or you're going to hear from later today and tomorrow. One of them is Grace Cordovano, who is a patient advocate and understands the technology side of things in the US extremely well and probably globally. But she does an amazing job of ensuring that the patient's voice, right? We talked about the community. Well, I think the patients really, when we try to narrow it in, is where we're trying to really get to ultimately is how do we make sure that their voice is included in this process, right? And then you're also going to hear from another colleague who's here, who her name's Kat McDavitt, and she's going to be talking in some ways also about, and she does a lot of work throughout the states in the United States, about these community-based healthcare settings, rural healthcare settings, and working with states and other areas and jurisdictions. In the past, the federal government left out incentives for the adoption of technologies in a lot of those settings, and we need to try to figure out how we can right that wrong. We actually had an initiative about 2 years ago called the Connected Community Health Initiative, or CCHI, which is focusing on how can we go back and try to provide more incentives for the adoption of technologies in community-based settings, to be used by community health workers, to be used going outside of the four walls of a hospital and into a community, and to have just as many equal incentives for those types of adoption of technologies. And then to make sure when we do that in that policy and in those funding opportunities that we're requiring the inclusion of those community-based setting providers, mental behavioral health specialists, others, as well as the patients from those communities to be involved in the development of those technologies as well. And there's a lot of different ways we can do that, but it takes some effort and some thought when you're crafting policy to be thinking 5 steps down the lane there, to figure out how can we make sure this is as inclusive as possible throughout the entire development process. Government has a lot of influence that it can wield through its policies, and we call them policy levers. And we need to make sure we're pulling those wherever we can to support health equity in every case. Yeah.
So I think we have time to squeeze one question in here. Just want to check if there's anything from the audience, anyone that wanted to ask a question to anyone at the panel.
Now is the perfect time, ladies and gentlemen, if you have any questions for our panelists. Feel free to. I'm sure there will be questions today. Not now, apparently.
Okay, no. It sounds good. So I just saw our time went up a little bit there, so that's helpful. I think the what I'm hearing from today, and I just wanted, if you could give me your summary of what you're taking out of this conversation, or sort of like the past hour or so that we've had here today. So from my perspective, I'm certainly taking out the data piece, like really be cautious on how you're thinking about the data, the provenance of the data, and it's just not the quality, which you mentioned, but also its intent, how you're planning to use it, and understanding, the broader intent of how you're wanting to use that data, how we're thinking about social determinants of health for the broader delivery of care. The role of technology, yes, a great enabler, but also, really thinking through the more broader community impact in terms of the delivery of that technology as being a key component here. Just wanted to get sort of, if we could go quick round robin in the sort of 3 minutes that we have left, if you could give me your takeaways and summary for today. We'll start with you, Stefan, and move our way down.
I just say, really do the homework. As you're building and deploying these solutions, really think about all the potential ways that it could have both a positive and a negative impact. And that latter part's the part that scares me the most, is the negative impact it could have. And actually, there's examples. We've seen studies on algorithmic tools that were being built to try to improve health equity. And when they actually broke it down, they realized they were actually exacerbating or making things worse. And so, for instance, there was a report issued from our members in Congress on the misuse of race data specifically. You know, in the U.S., we've done a lot to make more data available through something called the U.S. Core Data for Interoperability, or USCDI. Think of it as that minimal foundation of data that has to be available. And we've added, since version 1 of that, we've added a lot of data elements around social determinants of health, race, ethnicity, and language, other things, maternal health, other things that we think can help people build better tools to be able to evaluate things and understand how they're breaking down and how it's impacting different populations and subgroups. But we've seen in this study by Congress that I just referenced, on the misuse of race data specifically, where there was algorithms that were using race data because they wanted to make sure that it was, looking into these types of things, but it wasn't being used properly and therefore was having a negative impact on it. And when they tested the algorithm without the race data and they pulled it out, it actually was more effective and more equitable. So it's not always getting more data. Sometimes the question is, are you using the right data and in the right way? Even if it is race-related data. I think sometimes there's good intentions. People want to use, let me make sure I use the race data and I understand this so I can be fair here. But if you're not evaluating its impact, you may actually, miss the boat on the fact that you're actually making things worse, because that race data is coming from somewhere that may already have systemic biases in it.
I'm going to give a slightly more optimistic. Sorry, I'm losing my voice today, which
I like
is
that.
not
It's
the
sunny.
ideal. So kind of as a patient, as a clinician, as someone trying to build to solve these problems, I see the kind of the benefit to solving for health equity and providing algorithms to improve healthcare globally. We currently have reactive healthcare systems. I really see the opportunity with technology to improve access to healthcare, but also to improve preventative healthcare specifically. And I completely am with you on what you're saying. I think as long as we have our eyes wide open, that we are testing, that we are involving clinicians, that we're open about what the limitations are and how we are validating those and identifying the drawbacks, I think there's huge potential to solve for health and equity with algorithms and technology. So I'm going to end on a positive.
Great points.
I'm going to channel Katie as well and end positively. But back to that point, your algorithm or your tool is only ever going to be as good as the data that it's based on. So I think it's that functionality of making sure we're investing in good data collection, cleaning it, curating it, and using it in the best way possible to help mitigate some of these inequities down the line. Once you've got your AI solution, you've got to test that properly, but also testing it in an actual environment as well, making sure you've got the evidence for that as the solution is deployed. And that very much will raise any kind of unintended consequences that then you can mitigate. So I think it's that kind of continual assessment once that tool is deployed.
Great. Well, thank you very much, everyone. Really appreciate your inputs today and advancing this clearly very critical discussion. Thank you.